A very good morning to one and all. Welcome to this grand session of Grand Rounds. I don't think it can be a more greater grand finale for this entire year. So, moving on. I'm not sure if you've heard about the story about the Japanese fisherman and the shark. So here it goes. So we all know that Japanese love their sushi, right? So however, the waters which were close to the shore did not have that many fish. So then the fishing companies, they came up with this idea of bringing up big fishing boats, which went farther into the sea. And the farther the fishermen went, the longer it took for them to come back to the land. So the fish or the catch was not, very good. It was not very fresh. So then they came up with this idea of putting in large freezer boxes into the fishing boats so that the fish remain relatively fresh. But however, the Japanese still could taste the difference between the fresh fish and the one which was stored in the freezer. So what did they else do? They thought that, okay, let's just install some large fishing tanks within the boat itself so that the fishes are able to swim, they're not killed, they're not frozen. So by the time they come back to the land, they are, fresh enough. But still, people weren't satisfied with the outcome. Then somebody came up with the idea of putting a shark into the tank where the fishes were, stored. So what happened is the shark did eat some fishes, but they were fishes which were alive because they were fighting for their survival. It was a challenging environment. So I think one man who actually instills the idea to stop avoiding challenges, or rather jump into them and be the heck of them and finally enjoy the game as well, is none other than our own very chairman, who has won many accolades, and I don't think anybody needs to know about all of them. And the one man behind the entire empire of Agarwal's Eye Hospital. I welcome our chairman, Dr. Amar Agarwal, sir, to share his thoughts.
Thank you very much, Karpagam. So basically, Dr. Ashwin and Karpagam asked me to talk to all of you and those who are watching the whole program live on PDEK, which is pre-descemets endothelial keratoplasty. So when I'm going to talk now, basically you will have a range of doctors listening. Some of you don't know the game, some of you are in the game, and some of you are experts at the game. So I'll try to take it across the wide spectrum so that everyone will understand each step of the way. So before we start, let's understand first of all, if I can take this game first in the beginning to make it very, very simple and easy, and then we will take the game slightly to the higher level. Now, I'll just start this again. Now let's see first of all PDEK in 15 steps. It's important for us to understand what pre-descemets endothelial keratoplasty is. There are basically three types of endothelial keratoplasties. Let's understand that. One is DESCEMET, one is DMEK, and the third is PDEK. In Agarwal, we don't do DESCEMETs, we don't do DMEKs, we do only PDEKs. And you are doing approximately 100 keratoplasties a month. So just think for a second, if we are doing 100 keratoplasties a month and we are doing 0 PDEK, DESCEMETs and 0 DMEK, there has to be some reason. You don't even have to be an ophthalmologist to understand what is the reason. Very simple. Let's take DESCEMET. I am taking, let's say, anything, 100 microns, 80 micron, 150 micron, depending upon the surgeon and depending on the center which is operating on. Let's give a round number 100. So if I have 500 micron cornea, I'm adding 100 micron inside. That means basically it becomes 600 micron. That means the endothelium has to pump more. Instead of pumping for 500 micron, it has to pump for 600 micron. This is a basic problem. As I said, you don't have to be an ophthalmologist to understand why I'm saying this topic. So that's out. Now let's take DMEK. Fantastic. You are taking only 15 micron and putting it inside the cornea, so it's fantastic. But one basic concept that people are not getting here is simple. The endothelium and the descemets is stuck to the donor till the age of 40 or 50. That means if I have to do DEMEK in a patient, I will ask from the donor has to be above 50 years. I've lost the battle there itself. I've lost the battle there because that means basically I'm not able to use a young donor. I'm going to go for a 50-year-old, 60-year-old donor. I'm not sure how much sense that makes. Where does PDEK score? It has the advantage of DSEK and DEMEK both. So what it does here is basically you can use only 25 microns. Just 25 microns. Injects like a DEMEK. But the biggest advantage is any donor age. That means I can do it in a 1-year donor. I can take the eye from a 10-year donor. So my pool of donors also increases. And we by and large don't go above 40 years because we want healthy corneas. Now, how do you prepare the PDEK graft? If you see the monitor there in front of you, you are taking a 30 gauge needle. This is the cornea. You're looking at the endothelium now. Let's understand. I'm looking at the endothelium. I'm going to take a 30 gauge needle, go into the cornea. Now watch. I'm going to inject air. Here you can see we are injecting air. And as I'm injecting air, I'm creating a bubble. This is exactly the same bubble you create when you're creating dal, which is the unwashed bubble. Same bubble. Only thing when you're doing it at dark, you're doing it from the top. Here I'm doing it from the bottom. But remember, this is a type 1 bubble because as you can see, there's a space between the bubble edge and the cornea edge. If it had gone to the periphery, it would be a type 2 bubble. Now question comes, where is this air? So you have endothelium, you have descemets, then you have the Duas layer or the pre-descemets layer, then the air. If it was a type 2 bubble, where is the air? You'll have endothelium, you'll have descemets, then you'll have air, followed by the pre-descemets layer in the stroke. So it's a very simple concept. Now once I've created this type 1 bubble, all I need to do is take a knife, enter into this bubble. So once I have done this, you see I'm entering into it with a knife. Now inject some trypan blue inside. Once you have got the trypan blue inside the eye, here you see I'm injecting the trypan blue. Now it has stained the graft. Once it has stained, all I do is go around and dissect it. Now question comes, how much is this millimeter graft I get? I'll get about 7.5, 8, depending upon the case. You look at the first case, which I'm showing you. There is obviously a bullous keratopathy there, pseudophakic eye, but look at it, it's quite bad. I am not showing you a simple Fuchs type of cases because those are very simple cases. I'm showing you complicated cases, and as you will see, we'll take the difficulty more. Now, what's the next first step? I'm fixing a Trocar AC Maintainer. Please do not do this surgery with the way you normally will do DEMEKs or DSEKs. If you are doing that, it will not succeed. This is the way to do it. Take a Trocar ACM which goes through the sclera. I have connected it now to the air pump, which is the gas pump. All vitrectomy machines have an air pump inside. All vitrectomy machines. You should have a vitrectomy machine in your OR. When you are operating any endothelial keratoplasty, please keep a vitrectomy machine next to you. All you do is connect the air pump to that. Now I have got continuous air filling inside the eye. This is air pump assisted PDEK. So now, while we are removing the descematorhexis, you see I've got air constantly filling the eye. I have no chamber collapse. Now, all I do is I have made 2 side ports as you see, and a central main incision through which I have removed this bad endothelium and descemets. You can do the iridectomy at this stage. You could have done it before with the ad. Call is going to be the surgeons. Either way, choice is yours. Now we take the graft which we had cut. We can take a Jones tube. You can take a IOL injector system, whichever method you want, but it will be just like how you are doing DEMEK. Now remember this, switch off the air pump. I need the air pump off because when I'm injecting the graft, I do not want air inside because it will push the graft out. Now inject the graft inside. So you can see now from the side port, my assistant is injecting some slight fluid. If there is slight collapse, little bit of fluid only. Once I have injected my graft inside, you can see there the graft is inside. Now you could have pre-stamped the graft with the S stamp. Today in America, the Lion's Eye, the other banks also are all producing pre-cut, ready-made PDEK grafts. All I ask you is those who are watching this live can ask the eye bank to give you young donors. There is no point of doing PDEK if you are getting a 60-year-old donor. Okay? You should use the young donors because there are basically two advantages mainly. One, I'm going to use the young donor, and the second I'm going to show you just now the next big advantage. Now once I have done that, remember this, check the graft. It has to be curled like this. If it is the other way, that means it's upside down. The graft has to be like this, that is the edges have to be turned like this. Imagine that's the cornea on the top, the graft has to be like this, and then you know you're on track. Now you can see the edge. We are using this Endoilluminator to see better. But there are others who use either a slit lamp, some use a stamp, whichever one you want, keep it in fact, the graft has to be like this. And once the graft is like this is the Endoilluminator assisted PDEK. All I do is inject some air inside the eye. So watch now, I've unrolled the graft partly only. I don't even need to unroll it fully. I'm going inside and I'm going to inject some air. That's all. That means my central portion is attached. Once my center is attached, all I do is switch on the air pump. So now I have air continuously flowing inside the eye. Now remember, the second advantage of PDEK is, I told you have an endothelium and descemets, but next to it is a pre-descemets layer, which is about 10 microns only. The biggest advantage this is, it splints the tissue. That means it makes it stronger, like a DESCEMET graft. Now I can manipulate it. Whereas a DESCEMET graft, you cannot. All I need to is, air pump is inside the eye. I will just unroll the edges a little bit at the edges and make it bang on track. So remember this trick. I never do this tap, 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 dance, dance, dance in like they do in DMX. You know, it just doesn't make sense to me at least. There's a very simple process to follow this surgery. Once you have done this, you can see now the graft fully attached. Now the question comes, once you have the graft attached, take out the Trocar ACM and close up the case. The question comes at the end, how did this patient behave? So let's see how this patient behaved at the end of the day, because I showed you the case, how it was quite bad in the beginning. I have a good airfill inside the eye. I've checked it out immediately on table, how the patient is looking after the air is this 1 month post-op, and you can compare it to the pre-op picture, 3 months post-op, and again you can see on a comparison to the pre-op picture how the patient is looking, and you can see how the graft is absolutely clear, and you can see the 6 month post-op picture. Already the vision has improved to 6.6. Now since we have moved to this much, can we take this difficulty slightly more? So let's see if we can take it slightly more, and the case which I'm going to show you is slightly more challenging, but it's important for us to see this picture, because then only we will understand why we are doing PDEKs. Okay, look at this particular case. This came to me from Bombay, okay, which is about 90 minutes flight from here, as many know. Look at the cornea, it's scarred, quite badly scarred. This patient was operated 6 times. The patient had gone in for a surgery, for a cataract surgery, PC rupture, IUL drop, RD had occurred, name it, it had created a complication. Now this was the 7th time we were operating the patient. I'm taking off the epithelium, and even after taking off the epithelium, you can see I cannot see anything inside. I fixed my Trocar ACM. Okay, once I got my Trocar ACM, I made my 2 scleral flaps, and you can see I'm making with a 22 gauge needle an entry. because I know in these cases subluxation of some problem will be there in the lens. Now the problem is I am not seeing anything. So what I'm trying to do is I'm trying to take off this whole scarred structure there, which is the descemets and all structure, but look at it. It is stuck to the iris. It's so badly scarred. So now what I'm going to do is I'm going to catch this and I'm holding it with one hand and cutting it with a micro scissor with the other. So you can see that now we are cutting till that whole fibrous tissue comes off. Look how tough this case is. As I said from the beginning, I am not interested in showing you people simple flukes. Please understand. I'm showing you cases you will either would have gone for Boston Cape Pros or PKs, but in which we are going to do PDEKs. Now, once I have done that, I've taken it off. Now, still the cornea is bad, by the way. I still don't see much, but I see something structural moving around there. And you notice it is a subluxed IOL. That lens is moving. So before it falls down, I'm going to grab it somewhere, anywhere, doesn't matter where you catch it. Catch the haptic somewhere. Now do the handshake technique. So transfer the haptic from one hand to the other till you find the tip of the haptic. And if you notice, my assistant is holding an Endoilluminator to help me see slightly better. Once I've seen the tip of the haptic, I will externalize. Now my first fear of an IOL drop is gone. Okay? Now I do my vitrectomy. But remember, one haptic is out, my second haptic is still to come out. So all I have to do is now again go inside the forceps. So remember, you need two glued IOL forceps. Catch it anywhere, does not matter where you catch. First catch it. See, I've got it. And this is through that hazy cornea. Once,
luckily it's a three-piece.
Three-piece. It's a good point. Suppose it was not a three-piece IOL. Let's say it was a single-piece foldable IOL. I'd have explanted that and put a new three-piece IOL inside. So now you see I'm transferring it again from one haptic to the other. Catch the tip of the haptic. Remember that. You need to catch the tip. It's like my finger. If I bring it out somewhere in the middle of the flange, my finger will break. But if I catch it at the tip, I'm out. Now look how much of haptic is externalized. This was Gabor-Charrier's very good technique of intrascleral haptic fixation. You see, it's important to see the amount of haptic externalized. Because if you don't have enough haptic externalized, that much haptic will not be tucked and there will be a tilt. Why are the glued IOLs so successful is because of this reason. Because we see enough haptic is there to externalize and tuck. Now, once I have this done, all I need to do is create a Charrier's pocket with a 26 gauge needle, tuck both the haptics in. So what have I done? I remove that endothelium descemets complex. I've done the glued IOL. I've done my vitrectomy, but look at my pupil, it's large. What do I need to do? I want my air to remain in the anterior chamber. For that, I will make my pupil small. Simple thing is single pass, 4-throw pupiloplasty. So what we are doing in this simple procedure is very simple, which anybody in this auditorium or even watching can learn. Take a simple Prolene needle. 9-0, 10-0, game is yours. You decide. Pass it through the clear cornea on one side, going through the iris. Now leave it there. On the other side, you have a paracentesis. So pass a 26 or a 30 gauge needle through the paracentesis. Remember, paracentesis is only on one side. Now railroad the two. That's all. Once you have railroaded, the suture and the needle will come out through the paracentesis. Simple. Now remember, I need to bring this loop out. You see, I'm bringing this loop out through the paracentesis. Bring it there, take a forceps, catch, pull it out. This is single pass. Once only I have done. Once you have done that, remember the number 4. 4 times you pass it through. Once you have done it 4 times, 1, 2, 3, 4, pull on both ends. That is game, set, and match. That's all you need to do. Now I can make that pupil smaller. What have I done now? I made it like a pinhole pupil also, so that any astigmatism will get neutralized. I'm not talking on pinhole pupiloplasty, but just keep it in mind that also gets short. Look at my peripheral iris, all closed. So no air which is in the anterior chamber will go back. That means post-operatively, I will not get a graft detachment. Now, once you have done that, all you need to do is now simple inject air inside and see is the air remaining inside. Now, once that is there, you see I'm injecting air, it's remaining inside. I on the air pump. So I've got my fluid air inside the eye. Now all I do is I'm just checking. All my membranes are all gone off. My endothelium descemate is bad. I prepare my bubble. And again, as I showed you before, type 1 bubble. Take a knife, enter into it. Once you have entered into that, all you need to do is inject some trypan blue, dissect the graft, inject it inside. Like I showed you in the first video, unroll the graft. Just till the center. Take air, inject it inside so that the center portion is attached. Immediately when the center portion is attached, all the air pump, peripheral area is open, seal everything with glue. Now, question comes, how did this patient behave? Remember, VIP patient coming all the way from Bombay, operated 6 times, 7th time you are operating this patient, scarred. Ask anyone, they will say they will never do DEMEK in this. They will not even do DESCEMET in this. They will do only penetrating keratoplasty in this. But what are you trying to do? You're trying to do PDEK in it. And that's what we are trying to show you here, the advantages of PDEK. 15 days post-op. And now you see the same patient 45 days post-op. Look at the pre-op, look at the post-op. You've done a glue diet, you've done fourth-throat pupiloplasty, and you've done pre-descematorhexis endothelial keratoplasty. And the final pictures which I thought I'll just show you is just few cases before we close up and we can keep it for some questions is, look at this picture here. Pre-op, post-op. This patient had an anterior chamber IUL. You explanted the IUL, you did a glue IUL, you did fourth-throat pupiloplasty, and you did PDEK in this patient. Okay? And let me show you something else. Look at another case here. This is a one-eyed patient, only eye of the patient, failed PK. We are not doing any PK. But look at the anterior segment below, the iris is stuck. But with fourth-throat pupiloplasty, the angle has become open, and we have done a PDEK on this patient. So, failed PKs, don't do a PK again. All you need to do is very, very simple. You can do just a PDEK on the patient. Most important, and I thought I'll just show you is, we have brought out books on this topic, and this is the book on PDEK, which has been brought out published by the JP publications, only on PDEK, an entire book on PDEK, trying to teach people on what the surgery is about and how it can be done. I'd like to thank everyone, including those who are watching this program live, for watching the grand rounds on PDEK, and I'll be happy to answer any questions if they are online or here also from the auditorium.
Thank you, sir.
Thank you.
Thank you for this wonderful session. In Hindu mythology, we know the gods have multiple, they've got many powers, or astras has been called. So, sir actually ran through not only PDEK, but he also clearly explained about the use of the Trocar ACM, the Endoilluminator, the pinhole pupiloplasty. So, we are really open for questions right now from the audience here, as well as people who are connected live. Start.
Sorry.
Maybe we can refer, like we've also done a lot of cases with glaucoma drainage devices, aphakia, and all these things which are supposed to be things which people don't even touch. So I think PDEK has definitely revolutionized the field of endothelial keratoplasty.
I think this is an important point. One more thing I tell you what. There was another case which was referred to me by Dr. K.K. Mehta. You know, it was a young girl who had an iris cosmetic lens implanted in her eye.
Yeah, that's it.
Okay, and the pressure was about 50 millimeters of mercury. And many of you know K.K. Mehta is one of the best surgeons in the country. And luckily for me, he didn't do a glaucoma surgery. What I'm trying to tell you is, when these people have peripheral anterior synechial closed angle glaucoma, don't put a valve. Normally, anybody else would have put a valve or a trap. What we did was, we did fourth row pupillasty and brought the pupil to the center. The pressure became normal. She was counting on 1 foot with 50 millimeters of mercury pressure. It became 1.5 and we did with that a PDEK and she became all right. But the second point is, let's say someone has come with a valve or something very simple. With PDEK, there is no problem at all. That's what the advantage of PDEK is. It has the combination of both DESCEMET and DEMEC, and that's the biggest advantage I think.
Suppose with the valve, if the patient also had a disfigured pupil, what will you do?
If the patient has a valve and a disfigured pupil, very simple. What you do is make the pupil correct.
No, I want to do I know what you will do.
I also probably do similar.
So the answer is very simple. In such cases, when you have a disfigured pupil and a valve inside the eye, make the pupil all right. Please remember, then do the PDEK. So in other words, the moral of the story is make your anterior segment all right. You see the second video which I showed you? I made my anterior segment fantastic. Then I moved to the PDEK, all in one shot. I'm not taking the patient in 2 phases normally. Finish everything in one shot, but please make your anterior segment all right. If a patient has an ACIOL, I would not suggest leaving the ACIOL inside. I will take that ACIOL inside. I would put another inside, like a glued IOL inside, and then do the PDEK.
And with the valve, the only one thing, more that I'll do is many of these valves, the reason that they become decompensated in the first place is because most glaucoma surgeons put the valve in the anterior chamber. Okay. So that is one more thing that probably Sir and me both would do, is that you would shift the valve position from the anterior chamber, the tube, into the posterior chamber, which means between the iris and the IOL. So what happens is that keeps the future graft, the next graft, the PDEK graft that we are going to keep safe.
Sir, you do a pupiloplasty so that the air doesn't go into the posterior chamber, so thereby the viability of the graft is maintained. But suppose you have a large trab ostium and your air is going to escape through that ostium into your blood. What would you do in those cases?
So it's a good question. So first of all, why do I do pupiloplasty? One, because of what Dr. Karpagam you mentioned very clearly, it prevents my air from going back. But the second reason is any peripheral anterior signature are broken. So a closed angle will become an open angle. The third big advantage of pupiloplasty, I made it like a pinhole. So any astigmatism is neutralized. For these 3 reasons, we do the pupiloplasty. Now coming to the question, if air is moving out of a trap which has already been done by someone else before, suture that valve. Suture that opening so that the air does not come out.
Well, she's asking about the directivity along with the trap.
Yeah, that's what I'm saying. If there is an area there which has to be closed, seal it. I will seal that opening so that the air does not come out. Even if I was doing a normal trap in a normal procedure, at the end of the case, I always inject air to see my air is leaking out. Air should not leak out from the trap incision. If it does, put a suture in that trap area, it will not leak out.
So do you have any technique for vitrectomized eyes? Is there any technique you advocate?
So in vitrectomized eyes, a very good question again. The problem is, again, check, people will not do DEMEC. Why? Because you cannot unroll the graft. But in PDEK, again, there is not an issue. But one simple trick which we do is, we use a double infusion cannula technique. What do you see? You see the Trocar AC is for air. But in the back, I always fix a retina trocar for infusion so that I can monitor the fluid. That fluid from the vitreous cavity pushes my iris IOL diaphragm anteriorly. Once it comes anteriorly, I have a shallow AC and I can unroll my graft easily. So this is called the double infusion cannula technique, which we do for patients with vitrectomized eyes.
I have one question. All my advanced surgeons are asking very, very high level questions. I have a very basic question. I'm a new fresher coming out of this thing. If I want to start this procedure or any corneal procedure, basically I want to learn endothelial transplant, what should I do initially to start converting myself? I cannot go and do what you're doing at that level. So how do I move myself to this?
What you do first step is, remember, let's understand, as I said, why we are doing PDEK. You'll understand, common sense will tell you DESCEMET and DEMEC, in my opinion, would not be the way forward. It would be PDEK. That's the first basic thing. It's not an answer that let me do DESCEMET today. Okay, then after some years I learn DEMEC, and then later on I learn PDEK. By the time your life is over, because you lost 5 to 10 years of your life in this storyline. I'm not so sure it makes sense. So simple procedure. There are 15 steps to PDEK. What we have shown you is on YouTube, on various tube channels. American Academy site also it is there. Watch those 15 steps. If you go stepwise on those 15 steps, you will do it. Second thing is, please keep a vitrectomy machine next to you. You cannot do endothelial keratoplasty without a vitrectomy machine. At least you will not be able to do complicated endothelial keratoplasty. You might get away with simple flukes, which is not the answer in life. The answer is, if our surgery is good, I should be able to do it in any particular condition. It is not that I'll be able to do it only in flukes. The third thing is, start practicing to prepare the grafts with some bad corneas, which are being discarded. That way, you will slightly elevate yourself. If you are in a country where you have accessibility to good grafts and good eye banks, ask them to send you the PDEK grafts, which come ready-made. All you need to do is stain them, inject them inside, the game is over. So what I see the future of endothelial keratoplasty, this is the future. Like you get ready-made IOLs, preloaded, everything. All you do is injecting an IOL inside. Today, this surgery will become quite easy, that when you get a graft ready-made from an eye bank, it comes stamped, it comes stained. All you do is take it, inject it inside the eye, and it is over.
So we have an online question. So what about total aniridia cases, sir?
So suppose the patient has got total aniridia. In such cases, what we do here is, this is an online question. I want to thank the person who's asked the question. What we do is, one, you put an aniridic IOL. I do an aniridic glued IOL. This is an IOL which is a one-piece non-foldable IOL. It is not very expensive. If you have accessibility to an expensive product, you can use the iris prosthesis. Behind it, a IOL suture, and then you can fix back the iris prosthesis. That's the second alternative. Third thing is, suppose you have neither. At least put a normal IOL inside, glue it inside if it's aphakic without any capsule. If you are doing PDEK, you can get away with it. But my suggestion is the aniridic IOL, big advantage is it's large, it's about 9 millimeters nearly. You know, the whole thing, because it has got the iris drawn into it and the IOL inside. So when you inject your PDEK graft, the graft will not fall down into the vitreous cavity, because that is the one fear you have. So in aniridic cases, you can do an aniridic glued IOL with PDEK and you will still get great success.
Yes, I just wanted to say that even before we started, many of my students actually, PGs will not know what is the pre-descemets layer we are talking about. I'll be happy if somebody from the corneal department gave a lecture. No?
He explained it.
They should know. We are learning that there are only 5 layers in the cornea. No? I will want somebody to talk on what is dual layer and which we call it a pre-descemets layer. Anatomy of.
So just to recap on this fast, remember we had 5 layers, but Harminder Dua, with whom we have done a lot of work on PDEK also, brought out the 6th layer. So if you take it, you have got the epithelium, then you have got the Bowman's, then you have got the stroma. Now comes the pre-descemets layer or the Dua's layer, then comes the descemets, and then comes the endothelium. So actually, when you are doing PDEK, you are taking the last 3 layers. That is, you are taking the endothelium, descemets, and pre-descemets, which is about 25 microns. In DEMET, I am taking only endothelium and descemets, which is 15 microns. And in DSEC, you are taking endothelium, descemets, pre-descemets layer, and stroma, which is approximately, let's say, about 100 microns or 80 microns or 60 microns or whatever it is.
So there's a practical question online. What do I do if I get a type 2 bubble instead of type 1 bubble?
It's a very good question. And it's a very debatable question. I tell you very honestly, when we were doing PDEK in the beginning, if I would get a type 2 bubble, that means basically you got a DEMET graft. Okay? We were using it. But then eventually I began to realize we are getting all tough cases, important patients coming to me, and I don't want to go back to the OR and redo the surgeries. Today, if I get a DEMET graft, to be honest with you, I do not use it. We have our own eye bank here, you know, and what we do is we just don't use and prepare a DEMET graft if it comes also, because the difference is so much in our head between a DEMET graft and a PDEK graft. Previously, I was using it and I was really not happy. In such cases, like I showed you these complicated cases, Even if you get a DESCEMET graft and you try to put surgery in them, I tell you what, you will struggle. You will really struggle because you will not be able to unroll the graft the way so beautifully the graft reattachment rate is much better compared to a DESCEMET. So if I get a type 2 bubble, I discard. Before the patient goes into the ward, I'm very clear, I will prepare the graft. I will see my graft is good because I know the entire success of the procedure works one on me making the anterior segment all right, and on the second is I need a good graft. If my graft is not good, I will postpone my case. I have no issue. So prepare the graft, then get the patient into the ward for the surgery.
We had one of the senior consultants do a study on PDEK from infant donor corneas. Dr. Divya Ashok, ma'am. Can you just give a gist of this study?
Infant donors, like we had 3 or 4 cases in which we have taken a study, and we have got good results. The endothelial cell count, the loss was less, it was around 20 to 25% only, and the patient outcome, we used the eyes for patient more than 45 days. All these patients moved from less than 160 to 20 to 40, 25.
So the point what Divya is mentioning is, we were using infant donors. That means below 1 or 2 maximum. So we had the youngest donor was a 9-month-old donor. Just imagine a 9-month-old donor, when you get a cornea like that, you can't do it in PK because it will reject. You can't do DESCEMET because again that has stroma, it will reject. DESCEMET anyway cannot be done because I cannot take it off from the donor. PDEK you can do and it gives fantastic results because you got such lot of endothelial cells inside that inside an infant donor to use.
The size of the graft will be small. That doesn't matter, sir.
Size of the graft is approximately about 7.5 to 8 millimeters. Okay, sometimes you might get 9 millimeters, but by and large, let's call it as a round range of about 7.5 to 8 millimeters. The peripheral area, when it is there, it fills up. It gets closed up automatically by cells, and so there's no problem.
With infant donors,
With infant donors, it fills up even more. But with infant donors, you get still a very good graft, about 8 millimeters.
Yeah, this is probably a question which even I would like to answer because everyone keeps asking this question why the graft size is smaller than potentially it's smaller, but remember when people were doing PKs, most of the standard size of PK KERATOPLASTY used to be 7 or 7.5. And 7.5 is generally the minimum that we get with the PDEK. We often get 8, 8.5. Yesterday, the case that I did, I got 9 millimeter graft. It means it was going on. So that's I think a misconception that PDEK grafts are smaller. That really needs to be corrected.
I was specifically asking
infant donors, you'll get a very good graft size, no problems about it because it's the same principle.
If I have heme, you're telling me to do pupiloplasty, then you're telling me to do this. There's a chance that can bleed. If I have heme, do you still continue or do you stop? What is the?
It's a good question. So suppose you get a bleed, high fever, small, it's not stopping. One, remember I always have fluid in the eye. Always fluid is going on inside the eye. I never play this game with viscosity. We have fluid all the time so that the heme will get washed off. 2, at that time, if it's still not controlled, shift it to air. Wait for some time, the air will automatically close the bleeding. If some iris is still bleeding in a particular area still, all you do is take endothermy. Just go inside and cauterize that blood vessel and the blood vessel will close up and the bleeding will stop. So simple 3 tricks to stop the bleeding.
So as a beginner, I think it's an online question again. Tips to get the type 1 bubble always. What do I do to ensure I always get the type 1?
Always use younger donors below 40. If you go for older donors above 50, you will, the problem is when you start using donors above 50, the attachment between the pre-descemets and the descemets is weak. So invariably you might get a type 2 bubble. So go for a younger donor. Sometimes you will miss creating a bubble. There is no doubt about it because you do not know the exact plane which you are going inside. But as said and done, most of the time you will get it. And if you don't get discarded, the graft does not matter. Don't get discarded. But that patient is very important for us. So that patient needs to have the best graft available. Simple way, take a 30 gauge needle, go slightly through the sclera into the cornea in the central area. Don't even have to go right to the center and just inject with slight force and you'll be on track.
So in your experience, Yeah.
So sometimes when you take a number over, we assume that the cell count is high, but when you make the graft, scroll is very tight. So how do you?
So this is the flip side of it. The scroll might be slightly tighter. That is why if you notice we never do tap, 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 dance, dance, dance procedures. All I'm doing is get the center attached. It's little bit, the central portion is attached with the air on the air pump. That is why the air pump assisted PDEK is the way to go. Then the peripheral areas, I just have to unroll it. And it's in the peripheral areas I'm unrolling. So that makes life very easy for me.
How about Rho kinase inhibitors in your experience, sir?
Okay, we have Rho kinase inhibitors, and I tell you it's a great drug which is available. The Rho kinase inhibitors, the advantage is one, it reduces the intraocular pressure also. Two, it helps the regeneration. So both these help in the product. But most important, please, you need to get a PDEK done properly. Otherwise, these type of bad cornea, there's no way Rho kinase will work. Yes, it might work in early flukes, or when you're doing descemets stripping only conditions, where you're stripping only 4 millimeters of the endothelium. But in those type of bad cases, Rho kinase alone will not work. But if you have PDEK done and then you say supplemented by Rho kinase, it will definitely help much better.
I think this study was done by Dr. Colby, who had done a primary descematorhexis for the Fuchs cases, followed up with the Rho kinase inhibitor. Have you ever tried that in your experience, sir, with just descematorhexis working for Fuchs?
Actually, we did this. If you see the JCRS, there was one VIP patient whom I had done, in which by mistake I had done a descematorhexis. And it was a one-eye patient. But subsequently, in 2 months' time, the patient's cornea cleared to 6/6, and we published this in the JCRS without Rho kinase. That was long back before Rho kinase came into the picture. We have done descemet stripping. The only problem in the DSO, which is Catherine Colby has started very well by her, is the only problem which I see is you can do it only in Fuchs. You can't do it in these type of crazy cases. Second thing is some cases will fail, in which case you have to go to either DMEK or DSEK or PDEK. Third thing is it has to be done the central 4 millimeter and takes time to heal. Whereas in PDEK, when I do it, I will get the healing done within a week. Whereas in DSO, you will get, let's say, a month or 2 months. It takes time for the cornea to heal.
I have a question. I know this is a tough one for you to answer. But which cases will you not do PDEK or contraindication?
So when will I not do pre-descemet endothelial keratoplasty? If I find the patient is really bad with massive vascularization, one-eyed patient, and I want to make this patient all right, I might go for Boston Cape straight in those type of cases. But there's a problem in Boston Cape, which I have a real fear about. I do not know when a Boston Cape can land up with an endophthalmitis, because that is not in anyone's control. There are patients with fantastic Boston Cape, they do 20/20 vision, and suddenly 1 year, 2 years, 3 years later down the road, they suddenly come to you with an endophthalmitis, and that game is over. This is one fear which we have. So if I have a badly scarred cornea, I will say do a penetrating keratoplasty. I want to clear the patient and make him one shot good. Then you can go ahead and do it. But otherwise, I would go first for a PDEK, because the difference between PDEK and PK is huge. The difference is huge. As you can see, the pre-op and post-op of the same patient. Saying that PK is a great surgery. So if you are comfortable with a good PK and you don't have a good graft, go ahead and do a PK and get out of the case fast.
So the chances of rejection between PDEK and OPK?
Mike.
I'll just so that people don't stop referring cases for Boston Cape. It is a very beautiful surgery for heavily vascularized corneas, like sir said. And the way to, because we've got patients with very long follow-up, 6 years, 7 years, 8 years, so doing very well, one-eyed patients, and so many. And the key to keep them away from endophthalmitis is actual proper counseling to the patient before surgery, that they have to change their contact lens every month, which has to be done very strictly. And there's also a rotation of antibiotics that we do, and the proper regime, keeping the eyes clean and all, then they do very well. So, so those kind of corneas do well with Boston Cape.
Rejection is a big problem. So there is no comparison in rejection between a PK and a PDEK. In PDEK, I never seen rejection by and large happening. So in PK, you will get rejection. There's another problem in PK. You get astigmatism. And I've seen the best surgeons, whether they do DAL or PK, I have seen patients with crazy astigmatism. This is another problem. That means you've done a fantastic PDEK. Graph is absolutely clear, but the patient is not seeing. So it's as good as patient remaining blind. Then the only alternative will be PDEK-to, but that's a different story. But these are big problems in penetrating keratoplasty. I'm saying the best surgeons, you might think you do this, fantastic suturing, but that control is not in your hand, because I've seen patients with astigmatism with even good suturing done. Rejection is obviously a huge difference between PDEK and PK. Obviously, there's no rejection in PDEK because there's no stroma involved, whereas in PK, obviously there can be a rejection problem coming up.
We have another online question. Does stromal scarring clear up with PDEK? And if so, how does it happen? Why does it happen?
This is another very good question. That cases which I'm showing you, all these cases which I'm showing you are stromal scarred corneas. They will not improve with DMEX. They are improving PDEKs. Now the reason is why I'm not 100% sure, to be honest with you right now. What I see here is we are playing with very young donors. Otherwise, I cannot understand how the cornea becomes so clear from a pre-op to a post-op picture. Second big advantage is I am using healthy endothelial counts, healthy donor cells, which I think are making a huge difference, and there is no stroma in a PDEK tissue at all. There is zero stroma. In DESCEMET, you will have stroma however thin you go, because that's the basic principle of DESCEMET. If you want to do a DESCEMET without stroma, it becomes actually a PDEK.
What would be the main cause for failure of your PDEK? Can you repeat the question? What will be the main cause for the failure of PDEK?
My main cause, which I'm realizing with time, is that I compromise a little bit on my graft. I went on my graft, I didn't have a good graft. I said, okay, I don't want to postpone the case. I finished the surgery anyway. Then I will go for a re-PDEK, or it's a surgical mistake. This is the first biggest problem. The second is, don't make your anterior segment normal. Then that's your second problem. You see, in fuchs you will anyway get success, very good. But I'm talking about these very tough, challenging cases. Please make your anterior segment bang on track. Then go for the PDEK story, and then you will get the success you deserve. So if you ask me, the main two reasons why I would get a graft failure is my graft is not good enough. Not having good endothelial counts, too old a donor, the graft is not proper sized, etc. And two surgical mistakes. I mean, I've not made my anterior segment all right. I manipulate too much in my inside the eye. These are my second basic problems.
I think this is a world over problem, like the demand supply gap. There is only one donor cornea for 70 eyes to be operated on. So there is this concept of cultivated corneal endothelial cells. So what's your thoughts on that? So the cell therapy approach to endothelium.
They are still working on it. So till it comes into actual reality, I don't see it as a reality right now on table right now with everyone. It's there being worked on. Time will tell. I'm sure it will come out. But right now, from what I see here, I would say the best alternative, let's say if it was my eye, I would say I'll have a PDEK done.
There are many times what you have done is you have mainly done the anterior segment construction, glued and everything. If you didn't have a good graft, and later on you have done a PDEK.
Yeah, you can take it in the second phase. If you don't get a good graft, you can finish the anterior segment all right, and then take in the second phase the PDEK graft and preparation and do it also. That also can be done in 2 phases.
Have you tried the PDEK clamps?
Yes. The PDEK clamp was a very good technique which was started by Harvinder Dua. I have not personally used it. The idea is to fix a clamp so that the air does not leak from the periphery. Another one is Mark Soper has brought out a nice technique where he makes a circle with a stripper or a bent hook or something on the peripheral area of the endothelium so that you don't get a tight to bubble. So both the techniques are there and one can try them. I have personally not used either of the two techniques.
So this is done a before.
To prepare the PDEK graft, to prepare a good graft.
One more online question where they've asked, have you ever converted on table a PDEK case to a PK?
I haven't, to be honest with you. If I'm doing a PDEK, I have done it, but I have no problem converting also. If by chance I've done a PDEK and it has failed and I see I'm not succeeding, perhaps I might do a re-PK on the patient instead of doing a re-PDEK. But otherwise, by any chance, I might give the patient one more chance of a re-PDEK or something if it has failed. But then I will definitely then go for a PK. That means, no, this case is too complicated. I don't want the patient to go through more, so I might go in for a PK. So there's nothing wrong. If you've done a PDEK and if it is failed, just do a re-PK and make the patient all right. But the reverse is the problem. If you take a first shot as a PK, then you're stuck when you get into a mess. Here, if I've done a PDEK, all I need to do is convert to a PK later on in a second sitting. That's not a problem for me. But if I do first shot, simple cases, doing just PK, I'm not sure it makes much sense. That's why I tell everyone, I see people doing PK, I say, listen, hold on, don't do PK. Because look at your eye. Imagine you'll have these 16 sutures all around, astigmatism, all problems, open sky, you can get an expulsion. There are so many problems in penetrating keratoplasty. Do a PDEK. If it fails, nothing wrong, you can always do a PK later on.
Having said that, we also have many patients who have had corneal ulcers for whom a therapeutic penetrating keratoplasty had to be done just to get rid of that corneal ulcer. And then they may or may not continue to remain clear. In many cases don't remain clear. In those cases, just to let everyone know, we're having fantastic results doing a PDEK on a failed graft. So even if you have patients with a failed graft due to any reason, maybe it's a therapeutic keratoplasty or somewhere else a penetrating keratoplasty was done and it's failed over time, then PDEK is a beautiful way to get that graft to clear up again. And also for all the branches who refer cases to us, we have a post-operative regimen which is followed for these patients. So if any of you is interested in getting that from me, I'll be happy to share it.
I think there's a whole new insight into treating the Dr. Preeti. I mean, that.
How early can we refer? Suppose we know that intraoperatively we have a problem, and then how early can we refer the patient?
If there is a descemets detachment, please inject air at least, because that will solve most of your problems. But if by chance after, let's say 6 weeks, the cornea is not clearing, the chances of it not clearing are definitely high. I would say refer within after 6 weeks at least. Don't wait for 6 months, because by the time then scarring starts forming, then it becomes more difficult for us to handle. There is nothing wrong. Please understand, all we are doing is taking out the endothelium, putting a fresh endothelium inside. And when you see the patient post-operatively, nobody will even realize a graft PDEK has been done in the patient, because you won't make out. When you saw the post-op, can you tell me whether the PDEK was done in those patients? No, you can't. That's the beauty of the whole procedure. So all of those who are referring patients, my suggestion is this. This is the way. You can always start doing it. For example, the case referred to me was by Dr. Natarajan, leading ophthalmologist from Bombay. And he's got a great cornea team with him. But when he saw this case, he realized it must have been a very tough case. He sent it to me asking me to operate that particular case. That shows the greatness of Natarajan, who's not only the great retinal surgeon, but also the president of the All India Ophthalmic Society. And same with Keki Mehta. They are themselves doing the corneal surgery, but they have referred as a case because they felt it might be better off out here. So there's nothing wrong in that, I think, in referring out the patients, because let's look at it, at the end of the day, all of us are looking for the patient's well-being, which is the most important.
Thank you, sir. So one more question online. What's the ideal specular count which you would take for a graft and the thickness of the graft?
Okay, thickness of the graft I've told you will be about 25 microns, because in PDEK I get 25 microns. So that's very simple. The graft I would take nothing less than 3,000. So when you go to the 60-year-olds donors, you will not get 3,000. Rarely you will get. And then the amount of manipulation, you will have 25% cell loss. When I start with a high cell count, like 3,000 plus, then I know even if I get a 25% cell loss while manipulating this surgery, I'm still going to have enough cell count inside the eye.
Thank you, sir. That was an overwhelming response, both online and all your comments. This truly was the grand finale for the.
I'd like to thank also all those people who are online and all of this in the auditorium for coming here. I'd like to thank Ashwin and Karpagam for putting up this show of Grand Rounds. It's a great concept to teach people. Thank you very much.
Thank you.